Hello. In a minute it's Jan Williams, but just to get started, you should be able to hear my voice. You should be able to see, hear things. You were hearing the music before, so we've got the microphone on now, and Jan Williams is going to get started in a minute. Many of you have used webcasting before. I know that Charlotte says that you haven't. If you want, you've obviously already found the how to type in the chat room though, so do go ahead and do that. When Jan Williamson is talking in a minute, you might like to, if you have any thoughts, any comments, do feel free to type them, and then Jan will take her questions and comments at the end. But I will, without further ado, I'll hand over to Jan.
Hi. Thank you. Yes, this is a discussion about the research project that I was involved with a few years ago, and I'm not going to talk about the actual project itself and the detail within the project, but this is a follow-on from the presentation I did at the Penny Brown Centre, which I know some of you who are listening were there. And the point of this discussion is not the actual detail of the project itself, but very much the perspective for that for complementary practitioners, what the problems are, what the point of it is, do we gain anything from research at all, and is there any point in being involved with research as such. Please, as we go along, as Ray said, if you have any questions, please type them in, because I'm very used to doing presentations to people and taking questions as I go. So I would very much like it if you could participate as much as possible. Just to give you a little bit about my background, I'm a complementary health practitioner working with naturopathy essentially, but specialisms in reflexology and yoga and nutrition. I'm a director of a reflexology school in the UK, and spend most of my time teaching, some of my time being a practitioner, and a little bit of my time being involved with research projects. I essentially dragged my feet a lot about getting involved with research. I was not interested at all and couldn't really see the point. As a complementary practitioner, I thought that if I was going to do a research trial, it would diminish the work that I did, and I would not be able to work in the way that I normally do. So for years, that's the way that I felt. And in fact, the only reason I changed my mind was that it's in about 1998, 99, which sounds like a very long time ago now. It was because of my clients, really. I had a great deal of my client base were menopausal women, and they were reporting with improved symptoms, and I needed to know why, really, and they needed to know why. So it wasn't, my interest initially wasn't from the point of view of the research itself, but from the point of view of what my clients could find out about it and what I could find out that I could then contribute back to my practice. So it's essentially because of my clients, so that I knew that I needed to do a study about the menopause. My initial question was extremely naive, and something like how reflexology can help the menopause, which of course was completely useless as a research question. And I did learn a lot at that time about how to work on the actual question that you're asking and making sure that that was the correct question in the first place. I was very, very lucky in that I, at that time, had a practice in Exeter. I knew a lot of people who worked at the university or were involved with research. And so I had a great deal of support. And I think that's important, and I think that's one of the main problems why complementary practitioners don't get involved with research, because we're all encouraged to do it, but there's very, very little training given to research as a complementary practitioner. I was lucky, as I say, I had a lot of people who could give me support, a lot of people who helped me out and put me on the right track, really. So after much deliberation and burning the midnight oil, finally I came up with a study that was a randomised control trial. Again, you need to bear in mind the historical perspective on this, that at that time 1999, 2000, randomised control trial was seen as being the gold standard, and that's what everybody wanted to see, and no one was interested in anything other than that. I was really keen that this should be a rigorous study. I didn't see the point of doing one if it wasn't, and I was advised that an RCT was the way to go. I worked very hard and had a lot of help from Dr. White of Exeter University, who gave me a tremendous amount of support, and in fact, if I hadn't had that support, I would not have been able to continue, because the working with the kudos of Exeter University meant that I could get the funding for the study, which meant that I could then go ahead. It needed to be a randomised control trial. I would not have got the funding at that time if it hadn't been. I think things are different now. I think the climate is different now. I think it's possible now to be able to do studies that are not quite so measured, that are not quite so involved with numbers as such. At that time, it needed to be an RCT. We had 80 women who were reporting with menopausal symptoms, and we had a control group that had foot massage. Looking back on it now, I would not have that as a control group. There wasn't enough distinction between the two. But again, I was advised very strongly that I needed to try for a blind study. So the point of it was that the control group would have foot massage in an attempt to blind them, and so that he didn't know whether they got foot massage or reflexology. And one of the exclusion criteria, in fact, was that if someone had had reflexology before, they weren't allowed to be involved in the study. My view at the time was that I would do as rigorous a study as I possibly could, but being very aware that there would be mistakes. It was the first randomised control trial in reflexology, and there were bound to be mistakes. I viewed it very much as a learning exercise. Do the best I could, learn from it, and go on and do another one. And again, I was lucky because I was given so much advice and so much support from people who said, that's what the research study is about. You'll get things wrong, you learn from it, you'll do it better the next time. I had learnt a lot from it. I would do it differently if I were to go on to do more studies now. But as I say, the control group was foot massage. And there were, in fact, there were 80 women involved, but 76 of them were actually finally into the study because of various inclusion-exclusion criteria. Rather than going into too much detail about the project itself, again, I would like to say to you that what I really wanted to discuss was the reasons for carrying out the study were, as a practitioner, I wanted to find out information for my own practice and my own curiosity, really. I wanted to really look at what happened in terms of a reflexology practice and look at the wider issues and see why my clients, why women were improving within the treatments. I had various outcome measures on the study, Women's Health Questionnaire, which they were all valid outcome measures, obviously, and I was advised to measure particularly anxiety and depression in the menopause because it's such a huge study. We decided we needed to focus on specific measures that went on during the menopause, and we couldn't possibly study everything, so we picked out certain symptoms rather than all of them. The actual result, if it matters, were that there were changes within both groups. There were not, it was not scientifically significant improvement enough to show that the reflexology was more effective than the foot massage. I was, in fact, quite happy with the result of the study because I knew that there were benefits from the foot massage as well as the reflexology group, and I knew that we had a lot to learn from the study. As we reviewed it, as we went along, we realised that there were mistakes, there were things that could be improved on, and so I was viewing it very much as a study to work on from. There, I think the thing was that what happened was, I should say just a little bit about the study. I didn't do any of the treatments. I was very much the researcher. There were a team of practitioners who did both the foot massage and the reflexology. It was very much a sort of random allocation that was done via a computer at the university in Exeter, so we were not personally involved with who did which treatments, but the team of practitioners both did reflexology and the foot massage. And then what happened was, throughout the study, the practitioners were reporting back to me that the foot massage people were improving tremendously and getting a lot of benefits from it. I think, in actual fact, if we had had enough funding and we could have gone on for longer, we would have found that the reflexology group did benefit on a more sustained level, but we didn't have enough funding to do that, so we just had to work within the constraints that we had. We are also very aware of the wider aspects of the treatments that we were offering and what the women were reporting on that, but a lot of those were things that we couldn't measure, that didn't fit in with our particular scales that we were using to measure. So I think probably if I had to look at what I've gained from it, I would say I'm much more appreciative of the wider aspects of reflexology treatments and how that helps, or certainly helps some clients at particular times in their lives. We worked very hard to standardise the treatment. We made sure that there were a team of 4 practitioners. We made sure that we had a routine that was stuck to for the reflexology and also for the foot massage. And we tried very hard to stick to the rigour of the study as much as we could. I was quite keen that we should do that because I felt it was important as the first RCT that we should try and keep it as straightforward as possible. And I think that a lot of what I learned from the whole process was that as a profession, reflexologists need to learn a lot more about research. If we're going to take part in it, we need to have a lot more support. It needs to be there in a lot more of the training that we give. And also, I'd been told right from the very beginning that not to worry if it was a negative study. I felt what mattered that it should be a rigorous study, whatever the outcome. But sadly, a lot of people within the reflexology profession didn't view it that way. I think it got a bit muddled between research and promotion. And so because it came out as a negative study, a lot of people weren't happy about that. And that, I felt, was extremely unfortunate. It certainly put me off doing a lot of research for quite a long time. And I think that's a great shame. I don't think that's necessary. I think we could all have learnt a lot from it and gone on to have done a lot more. I think that I think probably what's important, and probably what I'd like to say to you, is to put to you the question of if you were going to do research, do you have any ideas about the subject that you would do? And I think that first and foremost, you need to have your own initial curiosity and to want to know about a particular topic, and then to go on from there, and also possibly to put the clients first. So to look at a particular subject that you feel is going to help your clients within your practice, and then work from there. I think it's very, very beneficial for practitioners to get involved with research. There are undoubted challenges. There are challenges to do with, it felt to me initially like a completely different world. The language was different, and certainly everyone's perspectives were different. And that I found it quite interesting and stimulating, and I think it would be a useful way forward for practitioners to get involved with research, but maybe you all feel differently about that. I think there are difficulties with getting involved with therapy, and and also by being a practitioner, and one needs to be able to stand back from it slightly and just realise that it's research and it's not promotion. And so I think.
Should we go back to that one and leave it on there
Yeah.
for a minute?
Yeah. So lots of questions really. The presentation I did at the Penny Bron Centre was very much surrounding my experiences of doing this study, not actually the study itself. I am happy to answer any questions on the study if anyone wants to do that. But more importantly, I'm interested in what practitioners feel about, is there a point to doing research and how could we go forward with that? I think we would certainly need to do more. From my point of view, needs to be more involved with the training of research, or to have more collaborative studies where we have practitioners and people who are very involved with research working together, because it can be extremely beneficial. And I think there are undoubted challenges, but certainly a great deal of benefits as well. So I think over to you for questions.
Well, can I pick up on some questions first? Jan, can you just tell us you had 76 women. That was 38 and 38, was it, between the foot massage and the
Yes.
Yeah, and then you got 4 practitioners. So actually, the variability that might come into play because of the practitioners and the 2 groups is you got relatively small groups, and therefore you didn't find any difference. Might just be due to the power of the study. Is that possible?
That's possible. That's possible, and I think certainly with hindsight, that yes, I would agree. I think at the time, because I was so green to the research, I just took all the advice really that I had, and I was told that was a suitable size to be able to find significant difference.
Yes.
But I think yes, certainly, if we had had more funding, I would have liked to involve more people.
And was there any indication that there was a bit of difference there, but just you hadn't reached a sample size big enough? I mean, the measures, did you do your measures at the beginning and then after either the reflexology or the foot massage?
Yeah, they did the questionnaires, I think, at 4 different intervals. So they did them right at the very beginning,
yes,
baseline, and then they did them after. They had 9 treatments altogether. So then they did the second questionnaire, I think, after 6 treatments, and then another one after 9, and then another one a month after that.
Right. So, but did you notice any? It looked as if there might be any difference emerging, or was it just that there was actually no difference at all?
There was a difference. There was a difference.
It just wasn't significant.
Wasn't significant.
Yeah. So it may be that with a bigger sample size, you might not have got that.
And also, I think what would have helped is if we could have gone on for longer, or we could have done a follow-up treatments a few months later.
Yes. So maybe that you treat that as a pilot study.
Yeah. Quite.
And also look at the validity of the different measures that you use, and you're saying that that maybe they're actually reporting anecdotally other things that maybe that next time round you would measure or record.
Certainly, and I think that's one of the things that I've taken from it, is that as a complementary practitioner there is a lot to learn from research, and now I think the research world has moved on, and certainly complementary therapies have moved on. So it would be beneficial now to do more studies, not necessarily RCTs, but ones that look at the wider issues really.
Yeah, well, you can always bring other types of measures and discussion, qualitative aspects into an RCT. We've got some questions. We've got at least 2 or 3 here, so you just bear with us out there while we catch up with what's being said, and just talk amongst yourselves. Give us your questions. So let's take Benny Goodman. He's in Cornwall. Says Edzard Ernst and Ben Goldacre discuss the use of RCT in depth in relation to intervention studies. Is still the scientific gold standard for appraisal of CAMs and other medical treatments. Therefore, we need to value this method. Don't be put off. Okay, so it's a comment rather than a question. Charlotte is saying, yes, but with complex interventions such as this, the MRC and other august bodies now recommend a staged approach, starting with small pilot studies and qualitative work. Yes, and I think that's really what we were just discussing.
Yeah, we've answered that one. Definitely, I agree with that.
So would you agree there's a better way to start?
Yes,
we've answered it.
Yes.
We answered it before you asked it. Elaine's asking, do we not owe it to ourselves and our professions, whatever they may be, to involve ourselves in research? Do you wish you had started research earlier in your career? Do you want to think about that one?
Shall I just take that one?
Yeah.
Sorry, can I just look at that?
It-
Do
it-
we
it-
owe
it-
it to ourselves as a profession?
To involve in research, and do you wish you'd started research earlier in your career?
No, I don't wish I'd started. I don't wish I started earlier. I'm very glad. Very glad I got involved with the project, and I do think I learnt a lot from it. I think that yes, as a profession, we need to be involved with research, and I think there's a great deal to do with our credibility as complementary health practitioners and our recognition in the wider medical world. Is that yes, if we had more rigorous research studies, then yes, undoubtedly our credibility would be improved. I think your question about asking if I got involved earlier is no, because I'm glad I got a little bit of experience behind me, because I think I could contribute that to the study. I would like to get involved with more research now, and I would be more interested in doing it now when I think there's more flexibility about the things that we've already been saying about it's not necessary to do an RCT every time, although I do value that level of study as well. But I certainly think with a lot of complementary therapy, and reflexology in particular, it would be very interesting to do a study of a different design. But yes, I agree that it is an important aspect of what we do, and it would be important for our wider credibility, I think, to do more.
So Benny Goodman is asking here about the design, and which is the difficulty of the placebo response, and how can you deal with this issue? I mean, you dealt with it by having something which perhaps the patients might have thought was reflexology, the foot massage.
Yeah.
I know that the studies of acupuncture have done, there's been quite a lot of work done, hasn't there, on placebo acupuncture, yes, where people think they're having acupuncture and it's not, either in the wrong place, or it's so do you want to comment about the placebo effect?
Yes, I think the placebo was interesting in that I initially didn't want to do the foot massage because I felt that they were too similar, and that was one of my initial concerns about the study. But again, it's a historical perspective, really. The funding that I got from it was then called the Foundation for Integrated Medicine. It's now called the Foundation for Integrated Healthcare. But they were very, very helpful, very, very supportive. Sent a lot of I did several protocols which went out to peer review, and they were very constructive. But I was also very aware that they were my funding body, and without a certain amount of compromise on my part, I wouldn't have got the funding. And at that time, it was decided that we should attempt a blind study, and so that was what we did. It didn't actually work as such, in that the majority of the people who had the foot massage did realise it was foot massage, and so from the point of view of blinding, it didn't achieve what it set out to achieve. Now, if I did it, I would do a hands-on therapy, so if you like, measuring the benefit of having that tactile contact, but probably would do a neck massage or hand massage as the control group, as the placebo. So there would be sufficient differences between the two groups, and not try to get an attempt at blinding at all.
Can I ask why? I mean, it seems to me that seems. I mean, there's the same sort of thing happens in my own work, and I'm nothing to do with complementary medicine. I deal with information for patients, and therefore, if you're trying to look at the effect of giving different information on patients, you have to have something to give them. So the only thing that in the end we end up doing is giving different types of information,
okay,
and saying that the trial is about information. So in this case, you've got, say, well, we've got something to do with your feet to help with your treatment. I don't see quite what's wrong with that. I mean, or was it that the people wanted and expected reflexology, and that therefore they knew what it was? I mean, maybe it's the way the trial was introduced.
No, the women were told that they would be allocated into a group, and they obviously weren't told whether it was going to be reflexology or foot massage. They were all very happy with that. There were no concerns about some women wanting the reflexology rather than the foot massage. They were all very happy with what they received. But it just did mean that, and that was my concern initially, was that we did try very hard with the foot massage to avoid reflexology strokes, working the reflex points, but inevitably, because we were using the feet as the medium, it was very, very difficult to differentiate what the benefits between the two groups. It would have been much nicer, not nicer, that's not the right word, I think it would have been much more effective as an initial study to have had something like neck massage against foot massage, and then we could have really measured the two, and then perhaps gone on at a later date to have done foot massage against reflexology.
Okay, we've got a couple of questions here which we're going to read out. In the meantime, let's put Jan's discussion points back up. So have another look at Jan's bullet points while we read out two more questions. Charlotte asks, can you give some examples of what you learnt from the study? And from Penny Bron, Cancer Care, where I think there's two or three people watching, in terms of how the study has changed your practice, did it cause you to make changes to treatments themselves and or information that you gave out to clients? And by the way, we've got about 22, 23 people watching in total. So.
Wow, okay, that's a surprise. Okay, so the first one was that Charlotte? Yes.
Charlotte, can you give some examples of what you learned from it?
Can I give some examples of what I learned? I learned to respect the feet as a form of treatment. And that perhaps sounds a bit naive to say as a reflexologist, but it showed me the enormous power of the feet as medium for treatment, because although, and I think it's important to say at this point, that although it's classed as a negative study because the differences between the two groups were not scientifically significant, from my point of view as a complementary practitioner, it was positive in that there were all of those women who came for treatment all benefited. They all, to varying degrees, had a significant reduction in their night sweats and hot flushes, and in a lot of the emotional aspects of the menopause. So the sort of off-the-record points that I learnt from it, really, in terms of my practice, in that I was able to see how certainly the women who were in that particular group benefited from what they all reported, that they were listened to, they were respected, and they valued that time enormously, when it's a group of women in our society who are not necessarily listened to. And I think that's a sad reflection, but that's actually what they said. And so I think I learnt a lot from that, in that it's the wider aspects of what I do within a treatment are very, very important, as well as the hands-on work as well. So
the other question was from Penny Bron, Cancer Centres. What changes, if any, did you make as a result?
I made very real changes in terms of the control group was foot massage, and I've introduced that over the years within my practice. Not exactly the same procedure that was used in the study, but developing that, working that, embellishing it quite a bit, making it much more elaborate than the one that was in the study, but respecting that within my practice. And also, I think, not actually within my practice, but being aware of the need to be a little bit more broad-minded about what I do, and being aware of the need to be professional in approach, and listening to what clients say in particular.
We've got one specific question here from one of our PhD students. Is, can you mention how you use visual analog scales in assessing anxiety? Did you do that? You used visual analog scales?
Gosh, this is racking my brains now, because it's quite a long time, and I only because I was aware this was going to be a kind of discussion about what was the point of research rather than the actual study itself. I'm just trying to think about the detail of the study. I know we did. I think, yes, that's what we did. We did a visual analog scale, which gave them, a scale between 1 and 10. They had to say they had to measure their anxiety levels on a scale of 1 to 10, and they did that. They did the questions all at, I think, 4 times. Baseline measurements after 6 weeks, after they'd had 6 weekly treatments, and then again they had then 1 treatment a month for 3 months after that. So they did the questionnaires again a 3rd time, and then again a month after the treatments had finished. So they did they did my MOP and the Women's Health Questionnaire and the visual analogue scales those 4 times, and it was a very, very simple analogue scale that just said, can you say in terms of between 1 to 10 how you would now measure your anxiety levels. So it was a very basic one.
There's another question from Penny Brown Cancer Centre, which is, what has this study taught us overall about the efficacy or not of reflexology?
I think overall it's taught us that what we need to do is to do more research studies and to know a little bit more detail about the efficacy of reflexology, and to know that yes, it is beneficial, and that we do need to see that yes, it can help. Certainly for the cross-section of people that we use, the menopausal women in that particular group, they all benefited, and certainly there is a real efficacy there. I would personally like to use it to develop more studies and to look at that in a great deal more detail. But I think it does show us that it has a real place, and again, it's the limitations of having a very measured, controlled study, in that a lot of the benefits that the women reported were things that we weren't able to include in the study, and they were things that were very beneficial indeed.
Can we go back to ask you out there in the chat room to give us your comments about Jan's 3rd bullet point, which I think is a very interesting one, which is, what are the difficulties of being a proponent of a therapy and remaining objective about the outcomes? I mean, how do you think, well, first of all, do you think there are difficulties? And secondly, if there are difficulties, how do you think they should be overcome? So let's hear your views in the chat room. We're going to be quiet for a minute here, I think, and let you talk, or type. We've got another 2 questions here. We'll take them in a minute. We'll let's hear your views on the 3rd bullet point. Go away.
Okay, so this is the first question was Charlotte.
Well, there was Elaine as well. Any other research on the
horizon? Any other research on the horizon? Me personally, no. There's nothing that I have planned as such. That doesn't mean to say that I wouldn't be, but there's nothing on the horizon at the minute. And Charlotte's question on
could some of your experience in the data you collected be used to design
could use for another trial? Yes, definitely. And that's absolutely how I would like to see it, really, that it was the first study, and I would love to see it as somebody to pick out all the mistakes and work on it and make it better next time. Yes, that would be good.
Then there's the Penny Brown Cancer Centre. You mentioned that you feel is mixing up a research and promotion. It's apparently lots of blurring. Do you want to comment on that?
Oh yes, the promotion and research is an interesting one. It actually never occurred to me, because I was, as I say, very was just very lucky at the beginning that I had colleagues, friends who were very involved with research, and they all said to me right at the very beginning, if it's a negative study, don't worry about that. Use it as something to learn from, and use it as a very first study and to move on from there. So I never viewed it as promotion at all. What mattered to me at the very beginning was that if I was thinking about improving the credibility of research and complementary practitioners, then it seemed to me important to do a rigorous study, and what mattered was the rigour rather than the result. And so I was very surprised that when it came out that the backlash came from people who felt that I was doing reflexology a disservice, because what I was actually trying to do was to improve the status of reflexologists. I was, my attempt was to do the opposite to that. I think the only way we can get around that is it's an education thing. I think we all have to say, those of us who train reflexologists, we have to make it plain to them that research is not promotion, and just continually bash away saying that, I think. And certainly being aware that sadly lots of things are always going to get reported in the press, and we have to be professional enough to be able to disseminate the information, I think. Yeah.
Okay, we'll pick up on a bit of a debate going on in the chat room here between Benny Goodman and Linny Price about picking up on the third discussion point, which was the difficulties of being a proponent of a therapy and remaining objective. So Benny says if one has invested time and energy into becoming a CAM practitioner, objectivity is difficult, or it is an issue, therefore the need for blinded randomized trials. And Linny makes the point, well, that's the same for medics as well as CAM practitioners, and I'm sure that is the case. I mean, personally, I think the answer, and I would say this, of course, wouldn't I, is that you need a multidisciplinary team to do the study.
Yes, yes.
What do you think, Jan?
No, I agree. I think that's what I learnt from it, is that there's a great deal of pressure on complementary practitioners to get involved with research, and I've heard it said many times, and I'm sure you guys have, that the medical profession aren't going to treat us with respect unless we get involved with research trials. I'm not sure that's actually true. I think what matters is the medical profession need to see that if we do research, we do it properly. They're not actually interested in the detail of it all. But I think mainly that we can't just expect complementary practitioners to do research without having very specific training. And what the thing that I found from the study that I did, it would have been absolutely impossible without a team of people who did know what they were doing. And that's why I have to stress that I was very lucky to have contact with Exeter University, the research fellow there, Dr. White, and other friends and colleagues who helped me out enormously with their very specific skills. And so having a multidisciplinary team would be ideal, because then you can bring in all the skills you need in order to do a rigorous study, and also it means that objectivity is possible, because you then have people who are not out to prove that it works, they're just out to do a good study.
We've got another question that we skipped over, which we'll come back to, which is from Linny Price, which was about what's the patient's reaction to taking part in a research study. Did they understand the concept of randomization? Were there any comments about receiving treatment by chance, particularly when they might be paying for it?
Okay.
So do you want to take that one?
Yeah. Yes, we were. Obviously, I had to get full ethical approval for this study, and so all of the women who got involved knew that they were going to take part in a research trial. Obviously, the carrot from their point of view was that they would get free treatment. They understood fully that they could be allocated the control or the reflexology, and we. I have to say, we turned away hundreds of women because they had had reflexology before, and that was our first exclusion criteria that we had to stick very rigidly to. It was all done in conjunction with their GPs as well. They had to we had to have GP approval for it all, and so from the point of view of the women getting involved in the study, they were absolutely clear at the very beginning that they knew that's what they were doing. We spent a considerable amount of time with each one discussing how the study would be conducted, and so they knew that all the way through. They were very, very happy to take part, because obviously they were getting 9 free treatments, and the only difficulty we had, I guess, was that after a little while they got a bit fed up with all the questionnaires, but they, we had to say that was part of it.
Did you have any dropouts of it?
That's why it says 76.
76, so
it was 80 to
dropouts,
start with, yeah.
That's quite a low dropout rate on most. We've got a question from Chris Hanks, which is one of the assumptions of many complementary therapies is the individual nature of the treatment to the client. Unlike allopathic medicine, where one pill fits all with that diagnosis, how then could this be taken into account when designing research? That's
a great question, and that's the real reason why I didn't want to get involved with research for years and years, because I felt that the standardisation of treatments within a research trial would negate the individuality of complementary health treatments. To a certain extent, we have to compromise on that if we're going to get involved with research. But I do think that even within the constraints of the study, we were able to standardise the treatment, but still able to meet the needs of those individual clients within the treatments that we gave them. So we certainly did not give as comprehensive a treatment as probably we would do within our practice, in that we had to have made sure that there was that degree of standardisation across the board. That was a limitation, and that was a compromise, but to a certain extent, I think it's inevitable with complementary treatments and research. I think with looking at it again in a different study, I would build that in some way so that we could individualise treatments a little bit more.
Can you not, in fact, do that by running to a sort of a protocol in a way? In other words, this is the complementary therapies protocol for how we would treat this, and therefore you may end up with patients getting slightly different treatments at the end, individualised to those patients, but you're still nevertheless following what is in effect the complementary therapy guidelines, in the same way that you might evaluate, say, a NICE guideline for a particular condition.
Yeah, I think so, and I think certainly now, 9, almost 10 years further down the line, our understanding of research and complementary therapy has changed and has developed, and I certainly think, yes, it is more possible to do that now, and I certainly wouldn't want it to put anyone off getting involved with research, because that could be built into the study, that there was a degree of flexibility, and that what we're actually measuring is how we do reflexology treatments, and so we need to do them as near to the way we normally do treatments as possible. Yeah.
We've got another. I'm going to put your discussion points back up on the screen again for people to think about while you have a quick look at this, and we'll just read out another comment from Elaine Gain. Cost of research. As research is often funded by other organisations' bodies, it's difficult to maintain control within your beliefs, needs and parameters. Do you feel financial awareness affects what is researched?
Yes, it does. I'm sure it does, and certainly it did with my study. I think that again, with the benefit of hindsight, I would have tried to have got more funding for my study, in that I would have been much more aware of the need to be able to give more time to those clients and to be able to extend the treatments a little bit. Obviously, especially at the moment, times of the credit crunch, I don't know how much funding is around for research at all. But obviously, we can only work within our financial constraints anyway. Maybe there'll be a time when there'll be a little bit more money available, and we can extend studies then. Yes.
I realise we skipped a question from Penny Brown Cancer Centre. Sorry, which was that I'm curious about your use of foot massage as a control in your research. As my experience of having been trained on a basic reflexology course and my own experience of reflexology treatments is that the reflexology session can also evolve. I mean, I think you did discuss the difficulty of blinding and so on.
Yes, I did.
And we go through it again a little bit.
Yeah, well, yes, we did. We myself and the team. I should say also, I'm not sure if I said it earlier, that I was quite keen that I didn't actually do the treatments myself. That was some small attempt to be objective, in that I was there to be writing up the study and not to actually be a part of the hands-on team. But what we did, we worked for quite a long time beforehand, because we did spend, it took about 3 years in all, from the time of starting the study to actually starting to plan the study to actually being able to start the treatments proper. It was about 3 years, so we had plenty of time to make sure we got the hands-on work how we wanted it to be, and we were very clear about the distinctions between the reflexology treatments and the foot massage treatments. The foot massage was very definitely a massage stroke or strokes, and not using any of the compression techniques at all that happen with the reflexology. So of course the difficulty and the reason for me saying I wouldn't do the foot massage again is that there wasn't a clear enough distinction between the two groups. Of course we were still working with the feet were still the medium, but we were very definitely not doing foot massage strokes, foot reflexology strokes when we were doing the massage treatments.
Okay, we've got another question from Benny, which is, why is there a negative reaction to RCTs by some CAM practitioners? I'm not sure that there is. I think perhaps it's because it doesn't allow for what we've been saying about the flexibility and the need for being able to tailor particular treatments to particular individuals. I think that it's a very tight study, as I'm sure you're aware, an RCT, and that's why it's got such a high rating. That's why it's seen as the gold standard. But it does present certain constraints, and when an awful lot of the work that we do as a complementary practitioner is to do with being able to tailor treatments to individual need, there are a certain amount of constraints within an RCT that mean that has to be compromised quite a bit. So, any other questions or comments? How's the weather in Japan, Faye and Tina? Faye Doris, who's up near the top of the list there, is logged on watching with Tina Wells in a hotel somewhere in Japan. Other people are logged on from around the southwest. If you haven't got any more questions, before you go, do let us know where you're watching and what you think of the webcast. But let's first of all carry on. We've got a few minutes left. Any other responses or points in relation to Jan's bullet points here, or anything else that she said in this last minute? Oh, here we are, Charlotte. There's a difference between practitioners being involved as practitioners when they can give their normal positive intention, care and support, and then being involved as a researcher when they may be required to have equipoise in order to randomise. I think it's much what you were just saying.
Yeah. Yes, I agree, Charlotte, totally. Yes, that there is a difference between being the practitioner. That's exactly why I didn't want to be one of the team doing the treatments. It did make it easier for me to be objective, because I actually didn't see any I didn't physically meet any of the women themselves.
Benny's asking equipoise. That's basically what you mean by this, taking a balanced view, isn't it? Yeah.
And so we tried as much as possible, that from my point of view, to be able to write up about the study. Although I did feel that it was my baby and I wanted it to be all as good as possible. But from the point of view of the women's responses to the treatments, I didn't meet any of the women involved. I spoke to them on the telephone initially, and then randomisation was done again by a third party, and then when they actually had their treatments, I didn't meet them then. So from my point of view, writing up the study, I was able to stand back from it and not see it as the individuals that were involved who came for treatment.
Okay, we've got another point from Elaine Gain. Remaining objective. Is it possible to remain objective when time and energy is spent on research? I might chip in on that in a minute.
Is it possible to remain objective?
I mean, I guess.
Yes, that's the question. Is it possible to remain objective when you spend so much time and energy on the research? I think so. Yes, I'm sure it is. Certainly what happened was the study that I did, we had the results in from all the outcome measures that we took. We'd got the scores, if you like, and we could only report on that. So we could just report very clearly on what the results were. There wasn't any, that's why I wanted it to be a rigorous study. There was no leeway at all. We couldn't disguise the results. We just had to be very clear about it, and certainly it's possibly because of that objectivity that we've had some of the criticism that we've had on the study. Really,
I think one of the things is very much comes down to the control. If you're doing randomised controlled trials as your research design, I think it comes down to the control. So if you've got an intervention and a control, well, you don't really mind which one, but as long as you don't have any vested interests in this, if you're quite happy for your intervention to be shown not to be the right thing, and the control which works just as well, then that helps. I think the researcher deal with the fact that when it comes out with the negative results, but you also have, of course, having all sorts of the checks and the blinding and other people being able to, the transparency of the way you've done things is all very, very important. Should we go back to there are some more points come in here. We've got one from Faye from Japan. Seeing this work was done so long ago, has any further work been done, any more written in the literature? And she's telling us that Japan's cool and wet.
Okay. Not as far as I know, in terms of as anything more being written in the literature. Certainly not as far as I know. I think it's probably time that some more was done, and it would be good to spark something off again, really.
And then we've got an interesting question back from Penny Bron, Cancer Care. Can you say a bit more about how you chose a research question, and what was wrong with your first question about the benefit of reflexology for menopausal women? Otherwise, how did you end up with that design and that research question?
Yeah, well, I think my first question, as I said to you when I came to see you in Bristol, was something like how reflexology helps the menopause, which of course was completely stupid research question, but I did have spend a lot of time then trying to decide, and those of you who've done research will know the importance of getting that very first question absolutely right, and so it was decided that because menopausal symptoms are so complex and there are so many of them, that what we needed to do was to decide whether we were going to measure emotional symptoms or psychological symptoms or physical ones. So we decided that we would measure psychological symptoms of the menopause, and so I think the question was actually a research study to measure the effectiveness of reflexology in women experiencing menopausal symptoms. So we didn't even say menopausal women, but we said women experiencing menopausal symptoms, to try and just keep it as open as we possibly could, really.
We're coming up towards the end of this. I think we've got sort of 5 minutes to go. We could take some more questions, but I think it must be Matt or somebody there in Penny Bronze suggested it'd be nice to know who's watching and where you're watching from. So do although we tend to know quite a lot of those people there. It'd be nice for everybody else to see who's who, so that for example, it's Benny Goodman's down in Truro. We know that Faye's and Tina are in Japan. We've got 3 people in Bristol. Let's just hear who you are, where you're watching from, and if you found this useful, I'm sure you will. If anybody wants a copy of the chat transcript, we can let you have that, unless anybody else has any objections to having their questions sent round to the group. So we do have the chat recorded. The video of Jan's presentation will also be recorded, and we will be posting that, hopefully, if I've pressed all the right buttons, we'll be posting that on our archive in about a week's time. So 1 or 2 last questions. If not, I'd like to thank Jan very much for coming here. Thank you, Jan.
Thank you.
Thank you all for your participation. So before you sign off, just say who you are, where you are watching from, and if you have any other comments about it. And I think we'll put some music on in a minute, and stay in the chat room as long as you like. You're very welcome to stay there and talk to other people, because the chat room doesn't go away, it stays there forever. So unless you want to say anything else, Jan, I think we'll call it a day, shall we?
That's fine. Thank you all very much for joining in.